The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar topic today is Getting Equitable Care When Diagnosed with a Brain Tumor. My name is Ambreen Maan, Program Manager here at the ABTA, and I'm delighted to introduce our speaker. Dr. Ugonma Chukwueke is a neuro-oncologist in the Center for Neuro-Oncology and Center for Central Nervous System Lymphoma at the Dana-Farber Cancer Institute. Dr. Chukwueke is engaged in clinical research efforts of novel therapies in the treatment of primary and metastatic brain tumors, and is the Neuro-Oncology Program Liaison to the Center for Cancer Therapeutic Innovation at Dana-Farber. Thank you so much for joining us, Dr. Chukwueke. You may now begin your presentation.
Thank you, Ambreen, and thank you to the ABTA for inviting me to speak as part of your webinar series. So my name is Ugonma Chukwueke, and as Ambreen noted, I'm a neuro-oncologist here at the Dana-Farber Cancer Institute in Boston. So in addition to my work seeing patients, the majority of my time is spent with seeing patients with all kinds of brain tumors. So primary brain tumors such as glioma and central nervous system lymphoma, as well as seeing patients with metastatic brain tumors, so tumors coming from other parts of the body or from other cancers. And what I do spend a fair amount of time doing is now writing and developing clinical trials, as well as working to ensure that all of our patients have access to the highest quality care in clinical trials. So I'm happy to share with you some of what myself and my colleagues have been working on over the last few years in understanding and ensuring that all of our patients have access to great care during their treatment journey. So in terms of what I hope to get across during the course of our session this afternoon, hopefully by the end of the session, you'll have a better understanding of what are the racial, social, and economic barriers that may limit the access to quality care and treatment for patients with brain tumors. Also, I hope to share with you some of the steps that are already underway to address these issues, and also to share with you and your family and caregivers what are the ways in which you can advocate for change and also how to reduce these barriers. So I have no disclosures. And so what I wanted to do with this slide, so I only know English, but I wanted to be able to say welcome in as many ways as possible, or at least share with you how welcome could be stated in as many languages as possible. Though I have this slide up, I also want to name that there's other barriers and other ways in which that I can't express myself to people because of hearing issues, vision issues, educational issues. And there's also people who I know who will be logging into this recording a little later on. So I also want to name that not everyone who can join is able to join at this moment. So with that, let's jump in and we can first discuss what are the barriers to care. So I just wanted to set the table in terms of what are the terms that we tend to use in this space in terms of equitable care. So I selected this graphic. There's many of these graphics which exist on the internet. I'm sure many of you have seen. There's one pretty popular one of some little kids who are at a baseball game and they're trying to look over a fence. And there's different levels of steps for which the kids may not be able to peer over the fence to look out into the baseball game. But I thought this image was pretty representative of what I hope to get across in the course of our session this afternoon. So in the first image of inequality, so you have this apple tree and you see that there's a difference in the access to the apples between these two little kids. The little child on the left is on the side of a tree where there's abundance of apples, and the little child on the right is on the side of the tree where there's no apples. So this is representing inequality. We have in the next, the panel to the bottom of this is demonstrating equality. And so equality just means that there's evenly distributed tools and resources. So both of these children were given ladders, but you can see it doesn't overcome the difficulty that the child on the right still has in trying to gain access to the apples. And if anything, it makes it a little easier for the child on the left who already has the abundance of apples on that left side of the tree to get access to the apples. On the top right, this is demonstrating equity and really just thinking about what are the tools that could be customized to identify and mitigate these inequalities. So things are a little bit better. The child on the right who's on the side of the tree where there's fewer apples has a taller ladder so they can access the apples, but it doesn't solve what seems to be the systemic issue in that this tree represents the lack of resources that can be inadequately distributed. And then the goal is obviously justice, in which we're trying to address and get at the systemic and the systematic issues which create these barriers to care, barriers to resources. So in this case, the tree is equally supplied with apples. Each child has ways of which they can access the apples in the tree in the form of ladders and other sorts of resources. So obviously this is the gold standard, and hopefully just a little bit of an illustration to show you what we're trying to do in the field of neuro-oncology. So what are the potential barriers to care with patients with brain tumors? So there's a number of different factors, a number of different barriers that we've studied, and I've been able to collaborate with many colleagues on over the last few years. And for the most part, these barriers to care are pretty similar across the board, whether it's oncology, cardiology, or other fields. There are those specific and more unique barriers to patients with brain tumors, which I'll get into in the next few slides. But I would say that, the one thing that we can discuss today, and I do want to name that we only have an hour, and so we can spend an hour probably on each of these individual barriers or each of these individual disparities. But I really just wanted to provide all of you with an overview, though noting and recognizing that many of these definitely would deserve a lot more time to go into in much greater detail. So we know that race and racism has been described as a barrier to care for all patients, for patients with brain tumors as well. We know there's also socioeconomic barriers to care in terms of access to care, in terms of difference in the quality of insurance, opportunity costs in terms of some patients who have jobs in which they're unable to get good insurance or they're unable to make it to their appointments. Age has also been noted as a barrier to care, in that we know that and specifically as it relates to clinical trials, older patients tend to not be represented highly in clinical trials. And there's a number of things which we believe underlie that, including that some physicians feel that older patients may not want to go on to clinical trials. And also in the way that we write our clinical trials, there's ways in which older people may be excluded because of some of the eligibility criteria, such as the type of, the quality of their organ function, the other medical issues they may have, other factors which may exclude inadvertently patients who are older from participating in clinical trials. We also know that there's disparities which exist as it relates to sexual and gender identification. Again, this is probably also worth another webinar on the part of ABTA, but we know that this in our field, as well as in other fields, is also a potential barrier in excluding patients inadvertently from clinical trials and also from achieving the highest quality of care. In terms of neurologic symptoms, I think this is where our patients differ from other patients in terms of accessing oncologic care. And like I said, I will discuss it in a subsequent slide, but I do think that this is a factor that is only starting to be more recognized in terms of why there may be differences in how our patients access care, or why their care may be different as opposed to patients with other kinds of cancer. We also know that there's physician and provider factors. So as I mentioned, I introduced myself as a neuro-oncologist. So I am a neurologist by training, by my primary training, and then I've done subsequent training in neuro-oncology. So all I see are patients with brain tumors. A small part of my practice is in seeing patients with other cancers who have neurologic symptoms. And then we collaborate with other oncologists to help in the care of those patients when those sorts of symptoms arise. So there may be issues or challenges on the part of providers who may not have, in that there may be different levels of expertise or different levels of knowledge, or even different levels of access to information that may, again, inadvertently impact the quality of the care that their patients may receive. So I put institutional and structural changes at the bottom, and that those are the ones that really do sort of float throughout, or sort of the through line throughout the difficulties and potential barriers to care. And also those are the ones that are probably the hardest to fix at an individual level. So we know there's potentially institutional factors which might impact how our patients access care. I know specifically at my institution at the Dana-Farber, one thing that we always want to get on our patients is to have their tumor sequenced. And what that means is that for patients that have had surgery or biopsies at other institutions, we look at a number of different types of information when we're trying to understand what their tumor diagnosis is. We know that one part is the name itself, so the histology. So when the tissue comes out at the time of surgery, when the pathologists look at the slide, what did those cells look like? Does it look like a glioma? Does it look like lymphoma? Does it look like meningioma? So really, what are the characteristics of those cells in that tumor specimen? The other piece of information that my institution obtains, and I think other institutions as well, is what we call genomic or sequencing information. So over the last several years, we've learned a lot about what drives the development of tumors and what fuels the growth of tumors. And we know that there's genetic changes, and I'll take a step back and say that when I say genetic changes, I'm not talking about genetics and what's inherited from your parents to yourself to your children. When we say genetics, we're speaking about what are called somatic changes, which are the changes that are occurring at the level of the tumor that cause the tumor to develop, to grow, to recur at any stage of the person's care. This testing is expensive. It's not always covered by insurance. I'm fortunately at an institution where we do have some philanthropic funds available to cover the cost of this for many of our patients and for patients with specific diagnoses. But I do recognize and name that this is not always the case at other institutions. And this can lead to different types of barriers, one in which includes, how do we expect the disease to evolve over time? When we're talking about prognostics, and none of us have a crystal ball, none of us know, what the overall survival or life expectancy will be. But this information can be instructive in terms of giving us a little bit of understanding of how the tumor, the disease may behave over time. And the other piece, and why we think of this as being critical, is that we know that this can also influence the types of treatments we may think about in the future. So many of specifically, I would say our clinical trials are what we call genomically guided trials. So meaning that whatever changes we found on the tumor will help to influence us in thinking about what are the next steps in treatment, whether they're FDA approved treatments specifically for that type of tumor, whether there are treatments that are approved for other types of cancers, or whether there's just treatments that we know that exist, that we potentially have access to those drugs and we can consider for your care. So again, the institutional factors, again, can also contribute to the differences in care that brain tumor patients may receive. And lastly, I also want to name that there's structural and systemic issues that, again, at the individual level are harder to impact. Things that are happening at the level of policy and legislation, things that have occurred historically throughout, the history of this country and throughout the history of the United States, that again, we're only starting to scratch the surface of and understanding, and also really thinking about how that impacts how healthcare is given in our country. And so those impacts are also felt in neuro-oncology and also in the treatment of our patients with brain tumors. So I think this slide is also instructive and and sort of describing where the barriers can take place. And so what I wanted to represent is, what I see as the treatment pathway for our patients. And I also want to say the caregivers and family members and friends, because, everyone is really on this journey together. So you have the development of symptoms, and for many brain tumor patients, it can be very obvious symptoms, such as stroke-like symptoms, such as a seizure, to symptoms that are much more subtle, such as a vague headache over the course of months, or very subtle changes in behavior that can be unexplained for some period of time. Ultimately, this leads to the presentation, so in the hospital or to your primary care doctor. From there, the next step is generally surgery. So we always recommend the maximal safe surgery that's able to be achieved. Sometimes that's everything. Sometimes it's just what the surgeon feels they can take out as safely as possible. From the point of surgery, we would then recommend for a consultation with oncology. So whether the neuro-oncologist, the medical oncologist, as well as the radiation oncologist, if that's decided to be appropriate for your care. And then we know that depending on where patients are receiving their care, whether they're comprehensive or designated cancer institutes versus, patients that are in more remote areas that don't have access to those bigger cancer centers, there may be delays in getting them from the point of consultation with their physician to the initiation of treatment. And I'll take the example of glioblastoma or high-grade glioma, which is, as this crowd will know, is one of the most malignant and the most aggressive of primary brain tumors, and in my view, one of the most aggressive human cancers in general. We know that time is a factor. So from the time that the tumor is diagnosed or the time that you have surgery, we're really trying to push to have treatment started somewhere between 4 and 6 weeks following surgery. And in instances where it's a biopsy, where the possibility of having more tissue taken out is thought to be unsafe, we're really pushing to have treatment started somewhere within 2 weeks. And so again, depending on where one may live or what are the healthcare institutions around them, this can create delays in terms of accessing care and really getting to definitive treatment for these tumors. We know that also there may be delays in terms of getting, or barriers in terms of the point of progression. So in many instances, clinical trials often become available only at the point of progression, depending on where one is obtaining their care. And so again, those same barriers that existed at the point of diagnosis will also persist at the time of progression when there needs to be changes made to the treatment plan. And what we're also learning about over the last several years is that as we think about the role of palliative care or symptomatic management, we think that this should be in parallel with what we call disease-directed therapy. So with your radiation, with your chemotherapy, and not just something restricted to the very end of life. And we know that sometimes those discussions around end of life may also be delayed or also potentially even avoided depending on the various barriers or depending on the characteristics of the patient and the physician. So we know that unfortunately barriers can exist along this entire treatment pathway. So I wanted to discuss a little bit about what is unique to brain tumor patients. And so for this crowd, I suspect everyone recognizes that, when we talk about health literacy, it doesn't mean the same thing as literacy. We know the health literacy is really the extent to which someone can read information and find information to make decisions about themselves or their family as it relates to their health care. We know that for patients with brain tumors, that can be impaired significantly. We have our patients with brain tumors, they may present with seizures, and that can affect any part of the brain that could disrupt their thinking, disrupt their physical and motor ability, disrupt their ability to hold a pen because their sensory symptoms they have new sensory symptoms. We know that depending again on the location of the tumor, for patients with tumors that tend to be towards the front of their head, that can impair their judgment, that can impair their insight. If there are tumors that are towards the back of the head, that can impair vision, or create distortions in their vision such that they're unable to read documents or understand a consent form. And then there's also, situations where what we call general cognition is impaired. So there may be other sorts of symptoms that will interfere with anyone's ability to make informed decisions or really understand the information that's being presented to them. So overall, this is why we always suggest that when new patients or any patients are coming to their appointments, it's always important, if at all possible, to have a caregiver with them. I always, even if the caregiver cannot come in, I generally say, is there someone I can call? Can I put someone on speakerphone? Because it's important to have a second set of ears to hear everything that's going on and to also think about important questions that may be helpful in terms of making decisions about your treatment. So I guess the bottom line is, so what and who cares about this? Why is this important? Why has ABTA dedicated a webinar to this? Why have I made this part of what I'm studying as part of my career, and other of my colleagues who are also doing the same thing? Why is this important? And I think from my own standpoint, I do see healthcare as an issue of justice. I think anyone who knows me or anyone who's worked with me, I am frustrated when I see that our brain tumor patients don't have access to care for various reasons. I think that healthcare should be fundamental to everyone's, is a fundamental right. And I think particularly in instances where brain tumors are such unique circumstances, is not anything that anyone can predict will happen. We know there's no risk factors, there's no known factors which influence the development of brain tumors. So I do think in such unique and very specialized situations such as this, access to specialized care, there should not be delays to that sort of care. And I do see it as an issue of justice. So I wanted to also show to the group a couple of important pieces of documents and some legislation over the past few decades. So the graphic on the left, unequal treatment, confronting racial and ethnic disparities in healthcare. This is really one of the first times I had ever heard of this concept of health disparities. This was published in 2002 by the Institute of Medicine. And this is where this concept of health disparities or gaps in healthcare was first identified. And it was seen across all specialties, in cancer and cardiology and pain management and access to care within emergency rooms. And so this is where the US government and I think a lot of other healthcare institutions started to see this as an issue of health justice and trying to work towards improving it. And then the other document that I have up here was the NIH Revitalization Act of 1993. And it just so happened that the late Senator Ted Kennedy, as all of you will know, who also died of a glioblastoma, was one of the senior lawmakers on this act. And this was just, it was in 1993, I think, that Bill Clinton was president. And this is where there were initiatives that were benchmarked in terms of addressing healthcare disparities, specifically as it related to women and minorities. So again, two pieces of information or two pieces of documentation that demonstrated that the government writ large was also taking this seriously. And this was just also published by the FDA. So they're also, again, really calling on industry. So many of the companies, the pharmaceutical companies, the biotechnology companies, to also prioritize the diversity and a broad representation of brain tumor patients in their clinical trials. And so this was a document which was published and circulated earlier this year by the FDA. And as I mentioned, through our academic society, the Society of Neuro-Oncology, we've also started to look at how we can understand and address the barriers to the care of brain tumor patients. This was some work that many of us were involved in a couple of years ago, where we identified what were the barriers to getting our brain tumor patients onto clinical trials. We know that across the board clinical trials, a lot of patients are not, do not enroll into clinical trials, not just in neuro-oncology, but across cancer and across other fields. In the field of neuro-oncology, I think that only about 8 to 10% of our patients are actually enrolled into clinical trials. I didn't put this graphic up, but the NCCN, which is the National Center of Cancer Centers Network, in their algorithm, their workflow for the care of patients with brain tumors, clinical trials represent, and this is their quote, that clinical trials represent the highest level of care for patients with cancer, and we extend that to brain tumors. And so we know that, we're trying to look at what are the factors which may influence why patients are not getting onto clinical trials, whether it's related to the patient, related to the physician, or like I said, related to other institutional and structural changes, which we need to take a look at. And so, just to put back this slide that shows sort of the barriers to care along the treatment pathway, we also started to look at what are the potential interventions that we could think about and how can we mitigate some of these challenges, some of these barriers to obtaining care. And so, what we've proposed are a number of things in terms of encouraging physicians who may be in a place where they don't necessarily see a large volume of brain tumor patients, having the instinct to refer their patients to high volume brain tumor centers, referring their patients to clinical trials. We also know that a number of outcomes can be tied to surgery. I think I mentioned to you earlier that we think of a maximal safe resection as having some prognostic value, specifically in patients with high-grade glioma or with glioblastoma. And it's also even more critical that, patients, if this is suspected, are being seen and operated on by neurosurgeons who are tumor neurosurgeons who have this experience in operating on these sorts of tumors. The other interventions that we've proposed are also earlier discussions of hospice and palliative care. Again, bringing this to the forefront to have in parallel with offering the treatment that's directed to the disease, also offering treatment and guidance for symptoms, and also the discussion of what end of life may look like for the patient and their family. And then we also recognize the role of the non-medical team members in terms of caring for patients, such as patient navigators who may be nurses and they may not be nurses, in terms of making sure that patients are getting to their appointments, they know where they need to go, when they need to be there. Something that we're piloting at my institution is that for patients who have difficulty with transportation or who are of lesser means, we're providing Uber vouchers, gas cards, parking validation, again, things to help to overcome some of those factors that may influence why they may not be able to get to an appointment. And also for patients who are minimal or no English speaking, providing them with interpreters, again, along the entire course of their treatment, from the moment that they check in to the moment that they leave the clinic, as well as, with patients that are calling in for symptoms or if they have questions, making sure that, again, an interpreter is available to help facilitate those phone calls and those questions. And so I wanted to bring to your attention, this is a piece of legislation which I just learned about, which if there's anyone who's logged in from New York, you may be familiar with this. So this is a bill which is currently in the New York State Senate. So the bill will ultimately be called, and again, this is contingent upon it being ratified by the governor of New York. The bill will be called Access, or the Access to Comprehensive Cancer Enhanced Services Strategy. And the overarching goal of this bill is to ensure equitable access to specialized cancer care. And I think one thing that I want to make sure that is clear, or that I do emphasize in this, is that we know that brain tumor care is very specialized care. As I mentioned, I'm a neuro-oncologist, so trained in neurology with additional training, subsequent training in neuro-oncology. There seems to be about 30 of us neuro-oncologists in Boston and in New York City, and we tend to all really be concentrated in very high volume, population dense cities. And by design, and that these are places where there are academic centers, medical schools, so hospitals which are very tied to medical schools and centers. And obviously there's fewer neurology trained neuro-oncologists or people that see only patients with brain tumors in areas that are less population dense, or as you move away from the coasts of the country. What this New York bill is proposing is that individuals who are in Medicaid and other small health plans offered through the state of New York, they'll be able to have access to what we call the National Cancer Institute designated cancer centers. So what that means is that patients, again, with rare disease and tumors that do require the specialized care, will be able to have access to that specialized care, hopefully with less challenges and no delay. As I said, it is quite important to have treatment initiated specifically for these high-grade glioma in quite a timely fashion. And so to my understanding, this is currently sitting in the New York State Senate's Health Committee and is sort of moving along the legislative pathway. Hopefully it is something that is successful in getting passed. And so with this graphic, and again, with many of those of you attending the webinar, logging in from many parts of the country, obviously this is a map of the United States. And what you can see, what the National Cancer Institute, so it's one of the institutes of the National Institutes of Health, they have 71 what they call designated cancer centers. Some of them are what they call comprehensive cancer centers. Some of them are not comprehensive cancer centers, and then a few of them are basic laboratories which are not involved in any patient management or clinical care. And the bill that's currently in the New York State Senate is proposing is that patients who have brain tumors, or not brain tumors specifically, but who do have cancer, should have access to care at these designated NCI designated cancer sites. And I think what this is really illustrating is that there is a level of care, and I'll say this as well for brain tumor patients, where in one institution you'll have a neuro-oncologist, a radiation oncologist, a neurosurgeon, a neuropathologist, a neuroradiologist. So all of the people that you see as part of your care, and then all of the people that are also behind the scenes in terms of making sure that your care is moves along seamlessly in one institution. I think that would be something that would be great to see and adapted for other sites throughout the country, other states throughout the country. So, I think there were a lot of takeaways from the COVID pandemic in terms of how we care for our patients with brain tumors. As I already mentioned, many of the multidisciplinary brain tumor programs, so meaning that neuro-oncology, neurosurgery, radiation oncology, they tend to be in more population dense cities. They tend to be associated with academic medical centers. And this is where many clinical trials tend to be housed, specifically early phase clinical trials. So what we found with telemedicine is that we were able to see patients throughout the country. And so that digital divide that we hear so much about was really minimized, if not even eliminated. That I could see patients in California, I saw patients in Seattle, Washington, all from where I'm sitting right now. That was at the point of the public health emergency, so some of the laws around medical licensure were relaxed. Unfortunately, now we've gone back to sort of the pre-pandemic license laws, and so those the flexibility we had with seeing patients virtually or even by telephone is not as such. But I think it is something that we are starting to look at as a field and sort of thinking about what are the ways that we can still provide great neuro-oncologic care, even if we may not be in the same city or zip code as the patient that we're caring for. And we know that there's other ways in which we can provide the wraparound multidisciplinary care, such as I know that what's still happening here at our institution is that the brain tumor support groups are actually both in person and also still available virtually. So that still allows people to connect and share their experiences of their disease as a group while not necessarily being in the same room. So what can you do to advocate for yourself and for your loved ones? And so one thing I always leave my patients with is that I always say you're the one that's in charge of your care, and not to pass off responsibility to you or your caregiver, but to know that, you know, if something doesn't feel right about where you're getting your care, who you're getting your care from, or about some aspect of your care, you have the right to make a change and to speak up. So that's something that I always encourage my patients to do. I think it's also important to know your team and to also make sure that you feel confident and comfortable with them. And if you're not comfortable if something seems off, it is your right to get another opinion or to transfer your care. I get this question where people are a little hesitant to transfer care and that they think they will hurt the feelings of whoever their other doctor is or cause a rift. And I don't think that's the case. And again, I think that this is such a rare disease with very specific expertise in very specific places. And so it's really important that you make sure you're getting the care that you need and that you deserve. And I think it's also important that, you know, for every appointment, you know, you as the patient or as the loved ones who are supporting the patients, whether in person or on the phone, don't leave the appointment until you feel all of your questions and concerns have been addressed. You know, in our institution, I am very fortunate. We are very fortunate that we have fantastic nursing line and nursing care, so that if there is a question that someone has, they can still ask it, whether electronically or they can call in. And I think I'll speak for myself, but also for my colleagues, we're also available by pager, again, regardless of what the issue is. I kind of like to know what's going on and rather not wait until, you know, there's some need to go to the emergency room or some other outcome. So I think, you know, everyone should feel comfortable and empowered to make sure that they know what's going on with their care. And I leave you with the phrase of just ask. And I borrowed this from, there's a campaign in Ireland and I think in other parts of Western Europe, really, and this is to encourage patients to ask about clinical trials and to be very curious about their care. And so I think this should be, I would leave you with you know, this piece of advice to just ask, and whether it is about clinical trials or other aspects of your care. Again, it's about you and it's about your family. It's your health. And I feel that everyone should be empowered to take charge of it. And so just to wrap up, I'm hoping that, you know, throughout this webinar, all of you learned that there's multiple barriers to the care of patients with brain tumors along their care journey. These barriers are critical to understand and address, as we think that, you know, we wouldn't just be addressing the barriers to improve the care of just marginalized patients. We think this will ultimately improve the care of all patients with brain tumors. And that's really what we're striving towards. And there's efforts that are taking place amongst stakeholders such as the Society for Neuro-Oncology, as well as the American Brain Tumor Association, and there's legislative efforts which are taking place at the state level. And then, like I said, just ask, feel empowered to ask questions, feel empowered to take charge of your care. And thank you.
Thank you so much for that wonderful presentation. We
Mhm.
do have time for questions. As a reminder, if you do have a question that you'd like to ask, please type and submit it using the Q&A button on the bottom of your screen, and we'll answer as many questions as time allows. So, Dr. Chukwueke, one of the first questions we have here is, it's obvious your passion for this, and it's so important, and we're so grateful that there are people like you out there in the neuro-oncology space advocating for patients and, mitigating, reducing these barriers. But what can patients and families do when their care team isn't as supportive and passionate about these issues as you are? What are ways that they can better advocate for themselves or find the proper care team that can address these issues and listen to their concerns?
Yeah, no, thank you for that question. And I think that's tough. I do recognize that I do feel that I'm in a place where we do care. I care. All of my colleagues care. This is something that is a personal and professional passion for all of us. I think that resources such as the ABTA are available in terms of trying to find access to other providers or other institutions. I will provide Ambry with other links that maybe can be emailed out to the group. The Society for Neuro-Oncology, again, is our academic neuro-oncologic society. So I think that hopefully there's also resources within our society that can also be helpful. What I have seen done also, and again, because I do feel that um, you deserve the care that, especially specifically in such a unique circumstance, such as a brain tumor diagnosis, I do think you can feel empowered to go straight to the top. And I've seen patients and families doing that. I've encouraged patients and families to do that. If this is happening at a specific hospital setting or institution, I think it's important to make the leaders aware of it. Patient satisfaction is a big deal these days. It should always be important, just in terms of quality of care, but I think there's also a public relations aspect to it as well. So I do think, you should take your grievances to the people that make the decisions. But also in parallel, reach out to these patient advocacy groups like the ABTA and our Society for Neuro-Oncology for other guidance.
Thank you so much for that great advice and insight. Another question we have here is asking about when finding an appropriate treatment center, what are some factors that patients and families should consider to ensure that they are getting the right treatment and the right care, the quality care that they deserve? As an example, you had mentioned in your talk the importance of going to high volume treatment centers.
Mhm.
What are other factors like that that patients should be looking into?
It's another great question. So I think I didn't remember to include this slide, but I recognize that, not everyone lives near a high volume center. What I have seen happen more, and again, I do think this is out of the COVID pandemic, which I didn't include on that slide, is you can also ask your provider, your physician, to reach out to their colleagues or reach out to other oncologists in the field for guidance. There is an electronic consult system that I am part of, and I think many other hospitals are part of, where oncologists, if they're looking for guidance as far as next steps in treatment or consideration of clinical trials, they can request this electronic consult. And it involves us reviewing your case, reviewing your images, reviewing all the information to date, and then we provide an opinion. Of course, this isn't the same as seeing you in person, but recognizing that not everyone can travel for various reasons, this might be sort of a workaround, at least for that moment. So I think if it's not possible to go to a high volume center, and I recognize it's not possible for everyone, this might be an option.
Thank you so much. And I did just want to share a resource at the ABTA for anyone that is looking for a good treatment center that they can reach out to for a second opinion or their treatment, we do have a brain tumor treatment center guide that's available on our website, and you can use it to find institutions either near you in your state. We also share a lot of information about what their care team looks like, what treatments they offer, what support services they offer. So please check out the ABTA website to access that brain tumor treatment center guide as well. All right. So another question we have, kind of along the same lines of what you were going with there about not being able to access or being able to travel to some of those treatment centers that we discussed. Are there any national level programs that you're aware of that provide assistance for patients that do want to travel for treatment to access some of that better, higher quality care?
Yeah, this is something that I wish there was such a thing, and it's I think right now it is mostly happening at an institutional level. I think I referenced in the talk that our institution is only just starting to look at that in terms of, what are the barriers and how, what are the small things that can be done to overcome them. What I will say is, including at our society level, we're also looking at this, whether there is philanthropy that can assist in transportation, or other ways to get access to care, the physically get you to your appointments or physically get you to the care that you're due. But I'm not aware of any national level programs. I don't know if at the ABTA, if there's any push or there's any discussion around that either.
Thank you so much for sharing your insight. That's definitely a need that we recognize, and we hope that together we can continue to improve that to ensure that all patients have access to quality care regardless of where they're located.
And sorry, what I will also add to that, and this may also be institution specific, but social workers and at least at our institution, there's someone called a resource specialist. There are also people that, they should have an idea or an understanding of the landscape of what may be available. There are, smaller grants that, depending on, the characteristics of the patient or the family that one may be eligible for, that can help to defray those costs. So, I think perhaps starting with your social worker, but then I'll also think and perhaps send some things on to Ambry to distribute to the attendants as well, whatever I can also gather from here.
Thank you. Yes, any resources that we talk about and touch on, we'll be sure to include it in that resource document in our follow-up email, so you all will have access to that. Now, another question we have here is asking about, so let's say a patient is not being listened to, or their questions aren't being answered properly by their healthcare team, but they unfortunately don't have the luxury of being able to change treatment centers or change doctors due to some limitations. What can this patient and their family do to better advocate for themselves or kind of mend that relationship with their healthcare team?
I want to say that seems quite challenging. I think, there's probably a few ways to go about it. One, again, I don't want to keep on referencing the ABTA, but I do think perhaps there's, there may be some aid through the ABTA that can be given in this situation. My instinct is to say to email me and I can talk to you further about it, but maybe that's not the appropriate thing to do. But I think, one other option or something else to consider, as I talked about empowering yourself, many physicians, many of us do have a presence online. And if, you can always feel free to get in contact with specific people or specific centers. If you have questions or an email, I don't know what state this person is writing from, but there may be an option for telehealth or something that can potentially help in helping them get the care that they deserve. So, perhaps I can talk offline with that person if possible to see how I can help.
Thank you so much for offering that. To kind of build off of that question as well, if if they're having difficulty with their physician or their doctor, is there someone else on the care team that you feel like they may be able to reach out to, that might be able to kind of be their stronger advocate and help them get the support they need? I know earlier on in the Q&A you had mentioned kind of going above and finding someone that can help to solve that issue. What's something they can do along those lines?
Yeah, so no, absolutely. I think going to leadership, or going, to HR, or if there's an ombuds person at that specific institution, your physicians, your nurses should all be advocates for you. So, perhaps there is a better relationship with one of the nurses on the team, or if there is the availability of a social worker, I think that also could fall within their role as well. So those are also some other strategies I can think of.
Thank you so much. This next question is asking about policy advocacy. So you had shared that bill that I think is in the New York Senate right now. How can patients and families engage in policy advocacy to support important policy changes like the one that you shared?
No, thank you for that question. So I think there's a few ways to go about it. Through the Society of Neuro-Oncology, as I mentioned, that's our specialty society. We do have an advocacy arm. So there's a number of, I think, neuro-oncologists, radiation oncologists, other stakeholders who form that committee. So we do take on issues as far as drug pricing. So I don't know if any patient on the call has received the medication called lomustine or gliostine. There was considerable discussion around the exorbitant cost around taking that medication as an outpatient. And so now the workaround is that at least in our institution, I think elsewhere, you get that drug in the hospital rather than, paying the exorbitant cost of taking it at home. I do feel that, unfortunately, unlike other cancers, such as I always use breast cancer because of Komen, brain cancer doesn't have a Komen. We don't have sort of the numbers or the money that I think the Komen Foundation has. So I think, starting at home, so supporting, for those oncologists on your team or the hospital that you're getting care at, if you feel compelled, if you feel that you are, if you feel generous to support them in terms of their efforts of bringing some of these questions up to higher levels of the lawmakers and politicians, that might be a place to start.
Great. And you had mentioned the Neuro-Oncology Society. Do they have positions or like panels that patients and families can join too?
That's a good question that I don't know the answer to, but I can find that answer.
Great. All right, let me see what other questions we have here. Kind of along that same line, you talked about clinical trials and how, unfortunately, there is a low percentage of patients that actually enroll in clinical trials. Are there research panels or advisory panels that take patients and caregivers to incorporate their voices so that when these treatments and trials are being developed, we're ensuring that their voices are being incorporated?
Mm-hmm. So I do think that's something that we are just starting to think about now, specifically as it relates to the trial design. The separate project that I'm working on, we're looking at what we call community engagement. And so having people who represent the community, whatever community means to you, or wherever your community is, who are involved at the point of designing clinical trials. So thinking about, is it necessary to come to the hospital 4 days a week? Can that be reduced to 2 days a week? Is it necessary to have these blood draws? Can we consolidate them? Or can we have you do the one blood draw on site and then do the other blood draw closer to home? So really thinking about what are those things that maybe on the face of it don't seem too significant, but they, as they accumulate, they can be more burdensome. So those are the things that we're also starting to look at. And also looking at what is the representation across clinical trials. Again, there was some data that I didn't show, but we know that, as we're looking at the different markers that are present on people's tumors, we know that we want to have a good representation when we're testing out these drugs to make sure that if these drugs are working, let's make sure they're working in everyone, not just a subset of patients who had the ability to get on the clinical trial. So all of those things, I think, are part of the sort of the way that we're reimagining how we develop and design clinical trials these days.
Great. Thank you so much for sharing your insight on how clinical trials are developed and ensuring that the patient voice is incorporated into that. All right. Now, we have a couple of bereaved caregivers who are on this webinar today and are wanting to engage in advocacy in honor of their loved one that they have lost, and to really raise a lot more awareness about many of the issues that we discussed today. Can you share some tips on how to get started, where to start? What are some first things that these caregivers and really anyone on this webinar today can take? So after this webinar, they have some key takeaways on actionable items of how they can better advocate and raise awareness for these issues that we've talked about.
So thank you for offering that. I do think it's great to start, again, if you feel grateful towards the physicians and the care team who cared for your loved ones. I think starting there is a great place, thinking about ways that you can participate in patient panels or caregiver panels, or, as you mentioned, to give back, as in honor of your loved ones. I think it's great to start locally. And then, again, sort of bouncing this back to Ambreen, thinking about how also you can be involved in the ABTA. And as I said, I will follow up with the Society of Neuro-Oncology. I'm not sure if there's yet a carved out space for that, but I think that is an interesting angle. And I think that would be a great way to continue the work and to honor the legacy of your loved one. So I will follow up on that.
Wonderful. Thank you so much. And I know the ABTA is going to continue conversations with you, Dr. Chukwueke, so that we can better understand how we at the ABTA can address these issues and continue to make a difference even after this webinar concludes. One issue that you brought up in your talk was some of the preconceived notions that providers might have, like not bringing up clinical trials with older patients, for example. What can patients do to address these biases? Is it them kind of just bringing up these questions themselves? And maybe you can share some examples of questions that patients and families should be keeping in mind, so that if their clinician is not bringing up the right information, they know to ask these questions.
Exactly, yeah. So I think that's another great question. If it's at all possible for you and your family to do your homework before the appointments, I think, I know not everyone can do that for various reasons. I had a patient this week who I saw from Texas, a young patient who has received care at great institutions throughout the country. They came to us though for another opinion. And I do think there was some bias that played into how that young patient was treated or how their family was treated. And the patient's mother did bring that up with me this week. And I said what I've already said to all of you, that I think you just have to speak up. You can call it out if you feel like you're the personality to do that. But I think your best weapon is being prepared. So if and this happens, and clinical trial slots are very dynamic. So you could look it up and you can see there's a slot available. A week or two later, by the time you have the consultation, the slot may be gone. But I think it's worthwhile. If you see these clinical trials that are available at that institution, come with your paperwork and then go through each one of them with your provider. And everyone is strapped for time. I don't think that's an excuse. As I mentioned, this is a rare disease. Things are very complex as it relates to brain tumors. we as physicians are still learning. So there's definitely an asymmetry of information, and that you as the patient and the caregiver may not have all the information. But I think to the extent that you can arm yourself with whatever you find, and again, I do sort of caution to restrict to sites that are verified and not giving out information indiscriminately. I think that will help in sort of making sure that you feel that you're armed and hopefully not being dismissed in terms of your questions and concerns.
Thank you so much for that thorough answer and your expertise throughout this webinar presentation. Unfortunately, that is all the time that we have for questions today. I just want to thank you again for joining us, Dr. Chukwueke, and engaging in this very impactful and important topic. And we hope that we can continue these discussions on improving access to equitable care for all patients.
Thank you.
And a special thank you to each and every one of you for joining us live online today and sharing your questions. We hope that you found this webinar to be informative and beneficial. Aside from our educational webinar series, the ABTA has a variety of programs that help support patients and caregivers throughout their experience. For more information about ABTA's programs, events, and services, visit ABTA's website at abta.org, email us at info@abta.org, or call the ABTA Care Line at 1-800-886-2282.